Welcome back to Deep Dive Ortho, the show dedicated to slicing through the latest orthopedic literature so you can focus on the critical updates impacting your practice. Today, we're undertaking a necessary revision of one of the most frequently injured bones in the human body, the clavicle. For decades, the mantra for these fractures was largely passive conservative treatment, a simple sling, and, hope for the best. Yet the evidence base has pushed us dramatically towards stratification and increasingly operative intervention. The landscape has profoundly changed. And for those of us treating high-demand patients, the pressure is on to ensure not just union, but optimal anatomical functional recovery.
That's really the crux of the issue, isn't it? We're talking about an extremely common injury. It accounts for a massive 35% of all shoulder girdle injuries and somewhere between 2 to 5% of all adult fractures globally.
So it's something every single one of our listeners will see regularly.
Absolutely. And while up to 82% of these occur in the midshaft, the complexity arises because the clavicle is not just a simple strut. It is an S-shaped structural component of the superior shoulder suspensory complex. The challenge for modern surgical management is getting to grips with that inherent anatomical variance.
And its complexity.
Exactly. And to guarantee long-term, high-level function and impeccable alignment, which, frankly, the traditional non-operative route simply cannot reliably deliver in displaced injuries.
It demands precision, which is why our mission today is to synthesize the most robust comparative studies and the latest technical advancements. We aim to help you, the clinician, refine your surgical decision-making, particularly for midshaft and distal injuries. We'll be focusing on updated risk stratification, evaluating efficacy and complication profiles, and crucially, addressing the economic reality of it all. Okay, let's unpack this. Let's start by establishing the epidemiology and the core biomechanical reasons why this bone is such a problematic site for injury.
Well, we see a very distinct demographic split, and it's based on the fracture location. Midshaft fractures are overwhelmingly prevalent in younger, high-demand individuals. We often see them in the second and third decades of life.
Right, so high-energy trauma.
Typically, yes. Think road traffic accidents, competitive cycling, or contact sports injuries. In stark contrast, the lateral or distal third fractures.
They're a different story.
Completely. They account for maybe 10 to 25% of the incidents, and they're far more common in older or osteoporotic patients. Usually the result of low-energy mechanisms like a simple fall onto the shoulder.
That distinction is key, but the anatomical structure itself, it almost seems designed to fail in that midshaft region, doesn't it? Especially in those younger patients.
It is a classic engineering failure point. The clavicle is a structural marvel, but it undergoes this radical transformation in its cross-section.
From flat to tubular.
Precisely. Yeah. It starts flat laterally near the AC joint, and then it transitions to a more tubular or prismatic shape medially. This junction, where the flat and tubular regions meet, acts as a classic biomechanical stress riser.
I see. So any significant load just concentrates right there.
Any significant bending or axial load will concentrate stress right at that point. That's why we see such a high incidence of midshaft fractures. The bone simply cannot handle the load distribution change at that transition. And understanding this inherent weakness really helps guide our fixation strategy when we do intervene.
So when we move out to the distal third, the anatomical complexity just ramps up, doesn't it? And it seems to be driven entirely by ligament integrity. This is where classification systems move from being sort of descriptive tools to critical decision guides.
Absolutely. The NAIR system, particularly the modified version, it's indispensable here. It focuses squarely on the stability afforded by the corticoclavicular or CC ligaments.
The conoid and trapezoid.
Exactly those two. Their spatial relationship is what defines the stability threshold. The conoid is the more medial stabilizer, inserting roughly 4 to 4.5 centimeters from the distal end, and it primarily resists superior translation. Then you have the trapezoid, the lateral component, which is about 2 to 3 centimeters from the distal end, resisting both vertical and horizontal forces.
So the location of the fracture line relative to where those two ligaments attach determines whether the fragment is stable or if it's going to be prone to displacement.
That's it in a nutshell. The NAIR system defines stability this way. Type I fractures are extra-articular, lateral to the CC ligaments, which are intact.
So minimal displacement, stable.
Almost always managed non-operatively. Similarly, type 3 fractures are intra-articular, extending into the AC joint, but again, the CC ligaments are intact.
Okay, so they're stable, but you still have to be cautious with type 3.
You do, because of the higher risk of long-term post-traumatic AC joint arthritis.
But the real operative debate, that focuses heavily on the unstable types. the ones with those alarming non-union statistics. We need to talk about type 2 and type V.
Type 2 is the critical clinical entity. Here, the CC ligaments are detached from the medial fragment.
And without that restraint.
Without that constraint, the medial fragment is immediately subject to the severe superior and posterior pull of the sternocleidomastoid muscle. This leads to high displacement and a non-union rate cited anywhere from 22 to 33% with non-operative care.
And within type 2, we have the nuances of A and B, which I suppose dictate the specific surgical challenge you're facing?
Yes. A type IIA is when the fracture is medial to both ligaments. The ligaments remain attached to the distal fragment. Type IIB, which you mentioned as being particularly precarious, is where the fracture occurs between the CC ligaments.
So the conoid is torn.
The conoid ligament is torn, but the trapezoid remains intact, or perhaps partially torn. This often leads to maximum displacement and maximal instability. I mean, the non-operative non-union rates for type IIB distal fractures are cited as high as 30 to 56%.
That's enormous.
It is. And then, finally, you have type V, which is a commented variant where the intact CC ligaments hold onto a smaller inferior bone fragment while the superior portion of the clavicle displaces dramatically.
So functionally, it's just an unstable type 2.
Exactly. It requires surgical stabilization.
So when you're facing these high non-union risks, whether it's a distal type IIB or a significantly displaced midshaft fracture, what specific patient or injury characteristics should trigger you to shift immediately to operative management? What truly defines a high-risk case?
Well, we have to look at two sets of data, the patient demographics and the injury morphology itself. Specific patient factors cited in the literature include female sex and older age, possibly due to baseline bone quality or, different patterns of loading.
But the morphology, the fracture pattern, that's the strongest predictor, surely.
Oh, by far. The morphological risk factors are the strongest predictors.
The radiographic thresholds. We all rely on those specific measurements for displacement and shortening, don't we?
Absolutely. And these are, I'd argue, non-negotiable for risk stratification. For midshaft fractures, the critical thresholds are shortening greater than 2 centimeters,
Right.
angulation greater than 30 degrees, or translation of more than 1 centimeter. These geometric parameters are proven to be strongly associated not only with higher rates of non-union, but critically with symptomatic malunion if you treat them conservatively.
I want to spend a moment on that malunion point. You said malunion is universal with displacement, but why is 2 centimeters of shortening that magic threshold for it becoming symptomatic?
It's a great question. When you exceed 2 centimeters of shortening, you start to fundamentally compromise the entire shoulder girdle mechanics. The scapula is effectively allowed to shift medially, which alters the fulcrum and the resting length tension relationship of the deltoid and rotator cuff muscles.
Which leads to scapular dyskinesis.
Scapular dyskinesis, altered kinematics, chronic pain, weakness, and potential impingement. So while some patients can adapt to a mild malunion, exceeding 2 centimeters is highly predictive of long-term functional deficits.
And that's really why the trend has shifted toward intervention to prevent that outcome in the first place.
Precisely.
That philosophical shift, moving from almost universal conservative care for midshaft fractures to a much higher index of suspicion for surgery, is perhaps the defining change over the last decade. Historically, the argument against surgery was that non-operative care offered acceptable results. What was the key evidence that finally undermined that consensus?
I think the consensus failed because we realized acceptable results were simply not adequate for modern patient expectations, particularly in younger, physically active people. Decades of retrospective data showed non-operative treatment of displaced midshaft fractures resulted in those non-union rates as high as 22 to 44% in some groups.
And guaranteed symptomatic malunion, as we just discussed.
Exactly, when shortening was significant. The objective of modern operative management using anatomically contoured plating is twofold. It's about guaranteed anatomical realignment and achieving enhanced stability, and that translates directly into a significantly faster union and therefore a faster overall recovery.
Let's get granular on the outcomes data then. How robustly does plate fixation actually translate into better healing versus conservative care?
Radiographically, the superiority is, well, it's undeniable. Operative fixation yields reliably higher union rates. In a well-cited comparative study focusing specifically on displaced and convoluted midshaft fractures, the operative group achieved a 98% union rate.
98%. And compared to what in the conservative group?
Compared to 87.3%.
Yeah.
That difference, a delta of over 10 percentage points, is significant when you're talking about failure rates.
And the speed of that union must be a critical factor for patient quality of life and getting back to their activities.
Oh, absolutely. The time to union is significantly expedited. In that same study, the operative group healed in just 2.37 months.
Whereas the non-operative group.
They required a median of 3.69 months. That 4-week difference in healing time is incredibly valuable for a professional, a student, or an athlete trying to return to competition.
And that speed advantage translates directly into better early functional scores. That's often our main justification for surgery, isn't it? The acceleration of recovery.
Indeed. Operative management reliably delivers significantly improved functional scores, like the DASH and constant Murley, specifically in the first 6 to 12 weeks post-injury. This accelerated return of strength, range of motion, and decreased pain is the primary undisputed functional benefit of surgery. It's a massive advantage for high-demand patients.
But, and this is the critical point that we have to discuss openly, the concept of functional convergence. We often counsel patients on the benefits of surgery, yet the literature contains this caveat that these functional differences often diminish or become non-significant at long-term follow-up, say 1 or 2 years. Why do we think that happens?
That is the pivotal question, and it really complicates the decision-making process. There are 2 leading hypotheses. The first is patient adaptation. The human body, particularly the shoulder girdle, is incredibly adaptive. Many patients treated conservatively develop a mild, non-symptomatic malunion, perhaps 1.5 centimeters of shortening, and over 12 to 18 months, they functionally adapt.
So they just recalibrate their biomechanics.
In essence, yes. They subtly alter their scapular resting position and movement patterns to achieve a functionally equivalent outcome, even if the anatomy is imperfect.
And the second hypothesis, is it a limitation of our scoring tools?
Precisely. The second hypothesis is that the general functional outcome measures we use, DASH, constant Murley, even the AC score, they may not be sensitive enough to capture subtle residual deficits.
Like a subtle scapular dyskinesis or muscle imbalance?
Exactly. Things that might persist in the Malunion group, but not severely limit activities of daily living. If the score is capped at a certain high level, a patient with a perfect anatomical repair and one who has adapted well might both score, say, 95 out of 100, masking small but genuine differences.
Which is why patient satisfaction is still so important.
It is. And interestingly, it remains higher in the operative group, particularly concerning the cosmetic results, because you've restored that anatomical length and contour.
So if we accept this long-term functional parity in many studies, we inevitably hit the economic reality check. Routine operative fixation costs substantially more upfront. How do we justify that?
The economic data is perhaps the sharpest point in the entire debate. Routine operative treatment is definitively more expensive. A comprehensive review cited a mean overall cost difference of, well, it was significant. Approximately $10,230 for surgery versus $7,923 for non-operative treatment.
A difference of over $2,000 per patient. That's substantial when scaled up.
It is. That clear financial disparity strongly favors conservative care for the general population.
But what about that critical variable time lost from work? If surgery speeds recovery, shouldn't it save enough on lost wages to offset the initial surgical cost?
This is where the data gets messy, and where we as surgeons must be critical evaluators of the statistics. The mean absence from work times, reported in some studies, are surprisingly similar, 49 days for operative versus 47 days for non-operative management.
That suggests no overall cost-saving benefit from surgery for the average person. But when I look at the range of data you've provided, the variability is just astronomical. 8 to 195 days for the operative group and 24 to 69 for the non-operative. Doesn't that huge variability in the conservative group undermine the reliability of the average?
You have hit the nail on the head. The means mask the risk. The conservative group carries a much higher risk of catastrophic failure, that 22 to 44% non-union risk we talked about. That results in prolonged disability, delayed secondary surgery, and substantial lost work time that skews those maximum absence figures.
Whereas the operative group offers a much more predictable recovery.
A much tighter, more predictable recovery curve, with the majority returning to work much faster.
So the argument for surgery shifts. It's not about general cost saving, it's about risk mitigation for selected groups.
Precisely. The conclusion for selection is nuanced. Surgery may only be more cost-effective in carefully selected patient populations. Those who absolutely require that reliable, better, earlier functional outcome, or those who can't afford the high-risk gamble of prolonged abstinence due to non-union,
We're talking elite athletes, manual laborers.
Exactly. Or patients presenting with multiple high-risk factors: comminution, older age, female sex. For everyone else, the long-term functional parity and lower initial cost still support non-operative treatment as a valid default,
Provided they accept that higher risk.
provided they accept the risk of delayed recovery or potential malunion.
That focus on early recovery and anatomical reduction demands increasingly precise surgery, which brings us to the planning phase. We know the anatomical challenges of the clavicle, particularly getting a plate to sit perfectly on that S shape. How are emerging technologies like 3D printing helping us overcome this?
Well, the introduction of 3D printing represents a paradigm shift in how we plan for complex orthopedic trauma. Fundamentally, surgeons have always relied on 2D imaging radiographs, CT slices, and then a mental reconstruction to visualize a 3D fracture pattern,
Which is very operator dependent.
and simply inadequate for complex comminution or the precise geometry needed for an anatomical correction. 3D printing literally transforms that high-fidelity CT data into a palpable physical model. It overcomes the limitations of pure visualization.
Can you walk us through the workflow? How do you get from a patient scan to a physical model you can hold?
The foundation is the DICOM data from a high-resolution CT scan. The critical step is digital segmentation. This is where we use software to define precisely which tissues we want to visualize. For bone, we'll typically select a specific range of Hounsfield units, often between 170 and 200, to capture the bone accurately while electronically discarding all the surrounding soft tissue.
And that becomes a printable file.
Once segmented, we render this structure into a digital 3D model, the standard STL file format. That file is then fed into the additive manufacturing machine for printing.
That explains the how, but in applying this to the clavicle, the focus has been on templating, specifically using the unaffected side as a mirror image. How reliable is that, given that we're not perfectly symmetrical?
That was the core uncertainty driving the research. A cadaveric study investigated exactly that, using a 3D printed mirror image of the unaffected contralateral clavicle to template the fixation plate. We know there are inherent anatomical differences, not just between individuals, but often between the left and right sides of the same person.
And the study found significant known variability, particularly related to sex, is that right?
Yes, the variability is significant. The research confirmed known sexual dimorphism. When they compared the 3D models of male and female clavicles, 7 out of 9 morphometric measurements differed significantly. Anatomical variation is certainly present. However, the truly impactful finding was the comparison between the mirrored template and the actual in situ specimen it was designed for. Despite the known biological asymmetry, the study found no significant difference in the majority of morphometric, plate bone dimension, and crucially, goodness of fit measurements.
So it was a near perfect match.
They used a quantifiable metric, the clavicle congruence score, and found that templating provided near-perfect anatomical congruence. It was a powerful validation.
What's the tangible clinical payoff of having a perfectly pre-contoured plate ready before you even make an incision?
The payoff is efficiency, precision, and minimizing soft tissue damage. The digital model can be produced incredibly quickly, often within 20 minutes, and the material cost is negligible, less than a pound. By pre-contouring your superior mid-shaft plate based on this accurate 3D template, you dramatically reduce the intraoperative time spent manually bending and checking it against the bone.
Which means less soft tissue exposure, less risk of error.
And ultimately reduced overall surgical costs. That's highly valuable in today's theater environment.
The technology clearly revolutionizes plate contouring, but its utility extends further, doesn't it? Into true patient-specific reconstructive solutions.
Absolutely. The next frontier is leveraging the 3D software for procedural planning beyond just templating. We can perform a virtual fracture reduction simulation, manipulating the separated fragments in the software to model the ideal reduced state. We can simulate the osteosynthesis.
And create patient-specific guides.
Exactly, which are critical for high-accuracy procedures like precise screw placement or defined osteotomy cuts.
Do you have a compelling non-clavicular example that really demonstrates this precision?
A fantastic example is in complex joint reconstruction, like the radial head. 3D printing has been used to facilitate the creation of a patient-specific radial head prosthesis from PMMA bone cement. But crucially, this was accompanied by a patient-specific surgical guide for an accurate radial neck resection.
And the outcome?
Follow-up at 18 months demonstrated excellent biomechanical restoration of elbow function and bone preservation at the interface. It really highlights the technology's capacity to deliver these highly tailored solutions.
Let's pivot now to the management of unstable distal clavicle fractures, the near type 2 and V injuries. We established that stability is the absolute mandate here, given the high non-union rate, yet consensus on the optimal technique has been elusive. It often mirrors the debate in AC joint management. We need to compare the three main families of techniques: hook plates, locking plates, and CC stabilization.
This is a critical comparison because the difference in outcome, particularly complication rates, is stark and should heavily influence current practice.
Let's start with the hook plate. It offers reliable fixation for small distal fragments, but it seems universally associated with mechanical irritation and high reoperation rates. Why does it perform so poorly?
The hook plate, or HPF, is mechanically effective for bridging that unstable fragment, but its fundamental design flaw is that it is an intra-articular device. It violates the subacromial space.
And that's the source of all the problems.
It is. Data consistently shows hook plates are associated with an unacceptably high rate of minor complications, sometimes cited as high as 42% in some cohorts. The specific problems are chronic subacromial impingement, local osteolysis, and pain, leading to a mandatory and often early reoperation for routine hardware removal once the fracture is united.
So it's a guaranteed second surgery.
In most cases, yes. And even major complication rates are cited around 4.5%. For a condition that is otherwise often manageable, these complication rates make the hook plate a highly undesirable option.
I think every trauma surgeon can attest that taking out a hook plate often feels like a surgery just to undo the previous one. The trend, therefore, moved towards fixation that avoids the subacromial space.
Precisely. Locking plate fixation, or LPF, became the preferred plating option. Modern pre-contoured plates are designed to match the distal clavicle anatomy and allow for multiplanar screw fixation.
Which is essential for grabbing that small distal segment.
It is. However, for the most unstable type IIB fractures, where the distal fragment is tiny or the ligamentous damage is severe, LPF alone is often insufficient. It requires corticoclavicular augmentation.
So using supplementary fixation like sutures or buttons.
Exactly, to restore that lost vertical stability.
When you compare LPF with augmentation directly against the hook plate, the safety profile seems overwhelmingly superior for the locking plate.
Absolutely. A robust comparative study looking at LPF combined with circlage wiring versus HPF showed a dramatic difference. The LPF group had a significantly lower overall complication rate, just 3.7% versus the hook plate's 40%.
40%, that's staggering.
And they achieved a 100% union rate compared to 80% with the hook plate. LPF provides stable bony fixation without the inherent mechanical irritation or the need for mandated routine removal.
So let's consider the third category: corticoclavicular stabilization or reconstruction. This technique skips primary bone fixation in favor of addressing the fundamental instability, the torn ligaments. How does this compare?
This approach is biologically sound because it aims to restore the native stabilizing function of the CC ligaments. Techniques range from open ligament reconstruction using autologous grafts to minimally invasive cortical button fixation. For example, an open reconstruction technique using an autologous palmaris longus tendon interwoven with Merceline tape and temporarily stabilized showed exceptional reduction maintenance.
So it restored the anatomy well.
The final measured corticoclavicular distance was nearly identical to the uninjured shoulder. It was an excellent anatomical restoration.
But comparing that to LPF, which fixation method best maintains that anatomical stability over the long term, particularly in the notoriously unstable type IIB?
The long-term data favors anatomical reconstruction. In studies comparing anatomical CC reconstruction against LPF alone for type IIB fractures, the CC reconstruction group maintained significantly better long-term corticoclavicular distance. At final follow-up, the distance in the reconstruction group was 7.66 millimeters compared to 9.33 in the LPF group.
And that was statistically significant.
It was. It demonstrates the superior resilience and stability offered by techniques that actively restore the ligamentous integrity, rather than just relying on the plate.
And what about the minimally invasive options, like arthroscopic assisted techniques? Do they compromise stability for smaller incisions?
The data suggests they do not. Arthroscopically assisted techniques, commonly using cortical button CC stabilization, show very good to excellent outcomes. Pooled data reports a mean constant score of 93.06 and high union rates, around 94.1%.
And the advantages are obvious.
Profound. Smaller incisions, significantly reduced soft tissue stripping, and crucially, a very low reoperation rate for hardware issues, only about 6%, which is substantially lower than traditional open methods.
So synthesizing this for the clinician making a choice, What is the current evidence-based hierarchy for an unstable distal fracture?
The conclusion is driven by complication avoidance and long-term stability. Hook plates should generally be avoided due to their inferior clinical results and unacceptably high complication rates. The superior options are LPF, particularly when carefully augmented, and primary CC stabilization techniques, either open reconstruction or arthroscopic buttons. And given that CC reconstruction offers proven superior maintenance of anatomical stability over time, it arguably represents the optimal strategy for restoring the native biomechanics in type IIB injuries.
Beyond choosing the ideal implant, the refinement of surgical execution to avoid collateral damage is paramount, particularly in a superficial area like the clavicle. The single most common complication in conventional plating is injury to the supraclavicular nerve, or SCN.
It is an occupational hazard of open clavicle surgery, and the incidence is, frankly, unacceptable. The SCN branches provide sensory innervation across the clavicle and shoulder region. During conventional ORIF, nerve injury is frequent. The reported incidence of postoperative numbness is alarming, ranging from 55% to a staggering 86%.
That's a tremendous burden on patient satisfaction, and the persistence of this sensory loss makes it a genuine complication, not just a transient issue.
Exactly. It is not transient. Studies show this sensation deficit persists in roughly two-thirds of those affected, about 66.7% of patients. And for many, it may be permanent. While it's not usually functionally debilitating, chronic sensory loss over the shoulder is a significant factor in reduced patient satisfaction. Traditional methods of protection have clearly failed to reliably prevent this.
Is novel technology, specifically ultrasound, offering a way to make nerve protection less reliant on surgeon experience and more objective?
Yes, the use of preoperative ultrasound localization is a highly promising technique. The SCN arises from the superficial cervical plexus, so it follows a predictable, albeit variable course.
And you can map that course pre-incision.
That's the idea. A high-frequency linear array probe is used to trace the SCN, locating its superficial terminal branches as they cross the clavicle. Feasibility studies confirm that the medial and intermediate branches can be reliably located and mapped over the skin surface preoperatively. This provides the surgeon with a map.
So the goal isn't necessarily to avoid the nerve entirely, which might be impossible, but to minimize the area of disruption.
That's right. The strategy is to guide an intraoperative skin retention strategy. By mapping the path of the medial and intermediate branches, you can plan the incision and dissection to retain the corresponding overlying skin where the nerve is running. This technique, essentially a precise surgical corridor based on imaging, is hypothesized to physically protect the nerve branches and reduce the overall area of postoperative skin numbness.
Were there any limitations noted in the studies?
Yes. It was noted that locating the lateral branch of the SCN was generally more challenging. This is likely due to its smaller diameter or lower contrast on ultrasound. However, successfully identifying and protecting the medial and intermediate branches, which supply the largest sensory area, still represents a major refinement aimed squarely at improving patient comfort and satisfaction.
We've spent a lot of time on primary prevention, but failure occurs. Let's address the reality of managing established non-unions and symptomatic malunions. We established that malunion is only addressed if symptomatic. The traditional revision strategy is accepted as the gold standard, but it has significant trade-offs.
The accepted gold standard for revising a symptomatic clavicular non-union has always involved three crucial elements: open reduction, rigid plate fixation, and adding an autologous cancellous bone graft, typically from the iliac crest. Autograft holds this esteemed status because it's osteogenic, osteoconductive, and osteoinductive.
But the significant caveat, the trade-off, is the morbidity associated with harvesting that graft.
Precisely. Harvesting the iliac crest graft adds considerable complexity. It increases operative time, raises blood loss, and most importantly, carries a substantially high rate of donor site morbidity, sometimes manifesting as chronic local pain.
So in a procedure designed to alleviate shoulder pain, you're creating a new source of pain elsewhere. It demands we question if the graft is truly necessary every time.
It does. And there is a growing, compelling body of retrospective evidence that suggests it may not be. Some specialist revision techniques focus intensely on meticulous biological preservation, thorough debridement, opening of sclerotic bone ends, and performing extremely robust, long-spanning plate osteosynthesis.
When you say long-spanning plate osteosynthesis, what does that typically involve?
It often involves using plates designed for reconstruction or revision, like a 3.5 millimeter reconstruction locking compression plate. These are longer, engaging multiple bicortical screws well beyond the non-union site to ensure maximal rigidity.
And is that enough on its own?
Well, one smaller series, reported a 100% union rate using this stability-focused technique without any bone graft at all. It suggests that in biologically active but mechanically unstable non-unions, the hypertrophic type stability might be the only missing link.
But what about the challenging atrophic non-unions, where the bone ends are clearly avascular and biologically inert?
For atrophic non-unions, stability remains paramount, but the lack of biological drive necessitates a graft. However, the traditional cancellous graft may not provide sufficient structural support.
So you need mechanical enhancement.
You do. This led to investigations into using a structural graft, specifically an autologous cortical strut bone graft, or ACSBG, to bridge the gap and add immediate rigidity.
So the question becomes, for these difficult cases, is a structural cortical graft superior to just packing the defect with cancellous chips?
A comparative retrospective study provided a fascinating answer. They compared ACSBG versus ACBG for chronic midshaft atrophic non-unions. The findings strongly favored the structural graft. The mean fracture healing time was significantly faster in the ACSBG group, 15.2 weeks, compared to 18.6 weeks in the ACBG group.
Over a month faster. And I assume that translates to better early function.
Precisely. The ACSBG group also showed lower pain scores and better functional scores at the 3 and 6 month marks. This is likely attributable to the superior early mechanical stability provided by the structured graft.
This finding is extremely important. It shifts the thinking. For challenging non-unions, the gold standard isn't just autograft, it's choosing the right type of autograft.
That is the ultimate implication. For revision surgery, the decision needs to be tailored. If the non-union is hypertrophic, maximal stability may suffice. If it's atrophic, however, you must use a graft, and the evidence suggests a structural cortical strut is superior to cancellous packing.
This deep dive has certainly clarified the modern algorithm for clavicle management. Let's synthesize the key shifts impacting the mid-senior clinician today.
I think the biggest shift is the refinement of selection criteria for surgery. For displaced midshaft fractures, surgery guarantees anatomical reduction, accelerates union, and provides superior short-term function.
Although we must counsel patients on that long-term functional parity if conservative treatment were to succeed.
Yes. And for distal fractures, decision-making hinges on the near classification. The evidence is now strongly condemning the hook plate.
So we're looking at locking plates with augmentation or primary CC stabilization techniques as the preferred options.
They demonstrate the best long-term outcomes, with reconstruction offering proven superior long-term anatomical stability.
And we've also seen how modern planning with 3D printing is enhancing precision and reducing time in theater,
as well as refining our complication avoidance with strategies like ultrasound-guided nerve localization.
One final fascinating point regarding recovery. The operative pathway fundamentally facilitates a quicker return to activity. The old 10 to 14-week recommendation for return to play seems outdated now.
The data on accelerated recovery is very encouraging. In meticulously treated adolescent athletes, return to competitive play has been safely achieved as early as 3 to 6 weeks. It confirms that for professional athletes or high-demand patients, operative fixation coupled with an aggressive, safe rehab program provides a distinct, measurable benefit in returning them to their life far sooner.
If this deep dive has provided valuable insight for your practice, please take a moment to rate and share the show with your colleagues.
I'll leave you with a final thought to consider. Given the high incidence of symptomatic malunion that results from conservative treatment of displaced fractures, and considering the proven efficiency and precision gains from technologies like 3D templating, should anatomical reduction be universally prioritized? That is, should we aim for a guaranteed anatomical result and the fastest path back to function for all active patients, effectively moving the operative threshold downwards, rather than reserving surgery only for elite athletes or those with extreme displacement? It raises serious questions about whether long-term functional parity truly justifies the risk of delayed union or guaranteed malunion in a significant percentage of our patients.